In this video, I'm going to walk you through a real patient case. A 72-year-old woman I'd call Margaret, whose symptoms were so convincing for early dementia that her family had started discussing memory care. And we're going to break down exactly what was actually happening inside her body, why the standard test that said she was fine was misleading, what the hidden signs of vitamin B12 deficiency look like before the labs catch up, and most importantly, what treatment looks like and what you should ask for if any of this sounds familiar. Margaret's daughter brought her in because her mother had become a different person over the span of about 8 months. She was forgetting conversations they'd had the day before. She'd stopped cooking. She said she just didn't have the energy. She lost interest in seeing her grandchildren, which was completely out of character. And here's the detail that made me lean forward in my chair. She'd fallen twice in the past month. No trip hazards, no loose rugs. Her legs just gave out. Her primary care doctor had run a workup. Thyroid, normal. Head CT, unremarkable. CBC, mild anemia, but nothing that raised flags. The working diagnosis on her chart when I saw her was probable dementia NOS. Now, an important clarification. Margaret did not have dementia. What she had was a severe vitamin B12 deficiency that had been progressing for what I estimate to be 2 to 3 years, quietly damaging the myelin on her peripheral nerves and her spinal cord. And this is one of the most underappreciated dangers in geriatric medicine because the early signs don't look like a vitamin problem. They look like aging. They look like depression. They look like dementia. And by the time the labs are clearly abnormal, damage has often already occurred. Let me walk you through what Margaret's symptoms actually were, because nearly every one of them had been attributed to something else. First, the fatigue. Margaret told me she'd been tired for a couple of years. Her doctor had attributed it to age, to her mild anemia, to maybe you're not sleeping well. But this wasn't normal tiredness. She described it as a heaviness, like wading through water. And this is important. B12 deficiency can cause a specific type of anemia called megaloblastic anemia. Your body can make red blood cells, but they come out large, fragile, and less efficient at carrying oxygen. However, it's worth noting that macrocytosis is only present in roughly a quarter of B12 deficient patients. Many have normal-sized red blood cells. Second, the numbness and tingling. Margaret had been feeling what she'd called pins and needles in her feet for over a year. It had crept up to her ankles, then her shins. Her doctor had told her it was probably neuropathy from borderline blood sugar. She was not diabetic, not even pre-diabetic by her A1C. But this is a classic presentation of B12 neuropathy. It starts distally, is symmetrical, and creeps upward. The tingling, the burning, the sensation of walking on cotton, that's demyelination of the peripheral nerves. Patients with B12 deficiency have been shown to have over 5 times the odds of paresthesias compared to those without deficiency. Third, the balance problems. This is the one that gets missed the most. B12 deficiency doesn't just damage peripheral nerves, it damages the posterior columns of the spinal cord. These are the pathways that carry perception, your brain's sense of where your body is in space. When those pathways are damaged, you develop something called sensory ataxia. You can't feel the ground reliably, so you compensate with vision. That's why Margaret's falls happened at night, getting up to use the bathroom in the dark. Her brain couldn't tell where her feet were. Fourth, the cognitive and mood changes. This is where it gets frightening. Margaret was apathetic, flat, forgetful. She wasn't just sad. She had lost the capacity to feel much of anything. B12 is a cofactor for methionine synthase, an enzyme critical to methylation reactions throughout the brain. These methylation pathways support the metabolism of neurotransmitters and the maintenance of myelin in the brain's white matter. When those pathways are compromised, the presentation can be inevitable from depression or early dementia. And here's what I want you to hear clearly. In a landmark study of 141 consecutive patients with neuropsychiatric abnormalities due to B12 deficiency, 28% had no anemia or macrocytosis at all. Neurologic and psychiatric symptoms can precede any hematologic changes. If you wait for the hemoglobin to drop or the MCV to rise, you may have already missed the window to prevent potentially irreversible neurological damage. Now, let's talk about something that I see repeatedly in practice, and it's one of the reasons Margaret went undiagnosed for so long. Her serum B12 level, drawn about 4 months before I saw her, was 245. The lab reference range flagged it as normal. The cutoff on her report said anything above 200 was fine. And this is where it gets tricky. That cutoff varies from lab to lab and can be misleading. According to the UK National Institute for Health and Care Excellence and the American Academy of Family Physicians, levels below 180 are considered diagnostic for deficiency, while levels between 180 and 350 are considered borderline and warrant further testing with functional markers. Margaret's level of 245 fell squarely in this borderline zone, but her lab report called it normal. The reason serum B12 can be misleading has to do with the proteins that transport B12 in the blood, transcobalamin and haptocorin. Only about 20% of total measured B12 is on transcobalamin, the protein that actually delivers B12 to cells. The rest is bound to haptocorin, a protein that does not deliver B12 to tissues. So, the total serum B12 test measures both active and inactive fractions together, and false negative and false positive results can occur in up to 50% of tests when using the lab's lower limit as the cutoff. The test you actually want, and the one I ordered for Margaret, is methylmalonic acid. Homocysteine can also be checked, though it is less specific since it can be elevated in folate deficiency and kidney disease as well. Margaret's MMA came back at 0.9, well above the upper limit of normal, which is typically around 0.27 depending on the assay. Her homocysteine was 22, normal is under 15. Both were unequivocally elevated. Her B12 was functionally deficient despite a serum level that looked reassuring on paper. If you or a loved one are over 60 and you've been told your B12 is normal, but the symptoms line up, fatigue you can't explain, tingling in the feet, balance issues, cognitive fog, mood changes, the words you need to say are, "I want methylmalonic acid checked." Do not accept a serum B12 alone as the final answer, especially if the level falls between 180 and 350. Now, why does this happen so disproportionately to older adults? Let me walk you through the mechanism, because this is where the prescribing cascade I've talked about on this channel becomes directly relevant. B12 absorption is a surprisingly fragile process. First, your stomach needs to produce adequate acid and pepsin to release B12 from the protein it's bound to in food, meat, eggs, dairy. Then your stomach's parietal cells need to secrete a protein called intrinsic factor, which binds to the freed B12 and carries it down to the terminal ileum in your small intestine where it's absorbed. Now, here's where it goes wrong for older adults. 3 things converge. 1, atrophic gastritis. As we age, the stomach lining thins and produces less acid. Autopsy studies have found atrophic gastritis in roughly 48% of individuals over age 70, compared with about 7% in those under 50. Less acid means less B12 liberated from food. 2, medications. Proton pump inhibitors like omeprazole and pantoprazole, some of the most commonly prescribed drugs in the Medicare population, suppress stomach acid. So does metformin, the first-line diabetes medication, which interferes with calcium-dependent B12 absorption in the ileum. In studies of metformin users, the prevalence of B12 deficiency has ranged from roughly 19 to 32% depending on the population studied, and the risk increases with higher doses and longer duration of use. One study found that each 1 gram increment in daily metformin dose conferred nearly a 3-fold increased odds of B12 deficiency. 3. Autoimmune gastritis. This is where the body's immune system attacks the parietal cells or intrinsic factor itself, making B12 absorption from food essentially impossible. Its prevalence is estimated at roughly 0.5 to 2% of the general population, but it increases with age and is more common in those with other autoimmune conditions such as autoimmune thyroid disease. The late-stage complication, pernicious anemia, is even rarer, with an estimated prevalence of 0.15 to 1%. Margaret had been on a proton pump inhibitor for 5 years for GERD. She had no idea it could affect her B12 status. Nobody had told her. Now, an important clarification. This is not a deficiency where you can just take a supplement and everything goes back to normal if you wait too long. The neurological damage from prolonged B12 deficiency can be permanent. The myelin sheath that insulates your nerves, Once it's been stripped away for long enough, the underlying axon degenerates, and axonal loss in the central nervous system does not regenerate meaningfully. I have seen patients who presented with spinal cord degeneration, what's called subacute combined degeneration of the cord, who even after aggressive B12 repletion were left with residual numbness, spasticity, and gait disturbance. The treatment stopped the progression. It did not reverse all of the damage. The cognitive symptoms are more variable. Many patients improve significantly with treatment. Some do not. The literature consistently shows that the severity and duration of symptoms before treatment influence the eventual degree of recovery. Months matter. A year of delay is not benign. This is why I'm telling you, if you're watching this as a caregiver, a son, a daughter, and your parent has been slowly declining with unexplained fatigue, neuropathy, balance problems, or cognitive changes, do not let it be attributed to just getting older until B12 has been properly ruled out with functional testing. So what does treatment actually look like? Let me walk you through it. For symptomatic deficiency with neurological involvement, which is what Margaret had, intramuscular B12 injections are a reasonable first-line approach because they may increase serum B12 levels more rapidly. A common regimen is 1,000 micrograms of cyanocobalamin or hydroxycobalamin, which is preferred in some countries, given intramuscularly several times per week for 1 to 2 weeks, then weekly until clear improvement is shown, then monthly for maintenance. An alternative approach described in the literature is 8 to 10 loading injections of 1,000 micrograms, followed by monthly injections. The reason injections are often preferred in patients with neurological symptoms is straightforward. Injections bypass the entire absorption problem and may achieve faster norm. It doesn't matter if your stomach acid is low, if you lack intrinsic factor, if you're on PPIs or metformin. The B12 goes directly into the muscle, into the bloodstream, and to the tissues that need it. Now, an important nuance. High-dose oral B12 at 1,000 to 2,000 micrograms daily has been shown to be effective even in patients with pernicious anemia because roughly 1 to 4% of an oral dose is absorbed by passive diffusion even without intrinsic factor. A 2018 Cochrane review found no significant difference in B12 normalization rates between oral and intramuscular supplement. However, that review noted that no studies had specifically reported on neurological outcomes. Given this gap in the evidence, many experts still recommend starting with parenteral therapy when neurological symptoms are present, as it achieves faster normalization. Follow-up involves monitoring symptoms and repeating the functional markers, particularly MMA, to confirm biochemical response. Margaret's MMA normalized within 2 months of starting injections. Her homocysteine came down to 9. Her energy returned before her neuropathy did. That's typical. The numbness in her feet took about 4 months to noticeably improve, and at her 6-month follow-up, her balance had improved enough that she hadn't fallen again. Her cognitive symptoms resolved fully over roughly 3 months. Her family told me, "We got our mother back." And the proton pump inhibitor, we had a conversation with her prescriber. She was able to taper off of it with dietary modifications for her reflux. Not every patient can, but it's a conversation worth having. So here's what I want you to take away from Margaret's story. B12 deficiency affects approximately 2 to 3% of adults in the United States. It is frequently missed, and it can be devastating when ignored. The symptoms hide in plain sight as fatigue, as neuropathy, as balance problems, as cognitive decline. The standard serum test can be misleading, especially in the borderline range of 180 to 350. The functional test, methylmalonic acid, tells you what's actually happening at the cellular level. And the treatment, when started early, is straightforward, inexpensive, and can be life-changing. If you found this video helpful, please share it with someone over 60 who needs to hear it. A parent, a patient, a neighbor. That share could matter more than you know. And if you want to stay ahead of health information that is specifically relevant to older adults, evidence-based, clinically grounded, and free of the noise, subscribe to this channel. New videos every week. I'm Dr. Kobe Nathan. Take care of yourselves and the people you love.